My name's Gregory Piazza. I'm one of the vascular medicine cardiologists at Brigham and Women's Hospital in Boston, Massachusetts. And I'm going to be talking about the HI-PRO trial focused on prevention of recurrent venous thromboembolism in patients who've had a provoked venous thromboembolic event. The HI-PRO trial really was born out of this recognition that for quite a while we have dichotomized patients with venous thromboembolism into either provoked or unprovoked. Unprovoked patients typically get long-term anticoagulation, no specific end date, they just keep going. Provoked venous thromboembolic patients who have an event in the setting of some kind of a trigger typically are treated for about 3 months and then stop. But there's this whole population of patients who've had a provoked event and have enduring risk, and no one really knows how long to anticoagulate those patients. So that really formed the context for HI-PRO. The study design of HI-PRO really focused on is single center but randomized controlled trial. And we identified a population of patients that were, as I had mentioned, sort of underserved by the current literature. Patients who had venous thromboembolism in the setting of a provoking factor, who had some sort of enduring risk. It could be obesity, it could be cardiovascular disease, it could be inflammatory disease. They had to have received at least 3 months of anticoagulation, and then they were enrolled into the study, and we randomized them to receive either Apixaban 2.5 milligrams twice daily, which is a direct oral anticoagulant, or a matched placebo. The key findings of HI-PRO really were, one, that we identified that patients with provoked venous thromboembolism and enduring risk factors do have a high risk of VTE recurrence. Low-intensity Apixaban with 2.5 milligrams twice daily was effective and reduced the risk of recurrent symptomatic venous thromboembolism by 87%. And it did that without increasing major bleeding as defined by the ISTH. Now, there was a numeric increase in the rate of clinically relevant non-major bleeding, but that didn't really reach statistical significance. So the clinical impact of HI-PRO is, one, that there's this new population of patients with provoked venous thromboembolism who have enduring risk that actually have a high enough risk of recurrence that we should talk to our patients about continuing anticoagulation, and that low-intensity Apixaban 2.5 milligrams twice daily is effective for reducing that risk of recurrence with a low risk of bleeding, especially major bleeding. For the evidence-based clinical practice guidelines, they up until now have really been limited to unprovoked venous thromboembolism patients, where they universally recommend long-term anticoagulation, and then patients with provoked venous thromboembolism, where they typically have recommended short-term anticoagulation. Now guidelines will have to incorporate both observational data, which for quite some time now has suggested there's a hazard to patients with provoked venous thromboembolism. It's not a negligible risk of recurrence. And with HI-PRO actually showing that the risk of recurrence can approach 10%, guidelines are now going to have to recommend likely a greater emphasis on shared decision-making with patients and talking about extending anticoagulation if there's some enduring risk. The key take-home messages of the HI-PRO trial are, one, that there is this population of patients with provoked venous thromboembolism and enduring risk who have a high enough risk of recurrence that we do need to talk to them about extending anticoagulation, and that essentially low-intensity Apixaban is a fine way of protecting those patients with good efficacy and a low risk of major bleeding. I think the next steps after HI-PRO will be to continue to refine our understanding of these populations of risk. In HI-PRO, we took patients who had enduring risk factors that could be identified, but there are going to be patients that probably were left out of the trial that have a high enough risk. So we could consider doing future trials with AI-informed risk scores, with polygenic risk tools, and even some biomarkers that might identify patients that might slip through the cracks of a clinical assessment but have a high enough risk to warrant receiving long-term anticoagulation.